Good morning and welcome to the February 2025 educational session brought to you by the Coding Corner. My name is Kristen Robinson. I am the creator and educator for the Coding Corner, and I have my CPC, CPMA, CCC, and CRC. Today's presentation is going to be on anatomical modifiers. Okay, so this is just a quick disclaimer that the information given within this presentation is known to be current and accurate as of the date of the presentation, and CPT modifiers are copyrighted by the American Medical Academy and are updated annually. The information in this presentation is not considered authoritative and should not be used as such. Today's agenda will cover bilateral procedures and MUEs, coronary artery modifiers, eyelid modifiers, finger modifiers, side of body modifiers, toe modifiers, and the modifiers XE, XS, XP, and XU, as well as proper uses for modifier 59. So let's start off with bilateral indicators. So Medicare has a fee schedule status. They use indicators for bilateral services that should be used to determine if procedures are allowed to be performed bilaterally. Bilateral indicators include the zero bilateral indicator, which says that it may be unilateral or another procedure code exists for services performed bilaterally. So this procedure code should not be reported with a modifier 50 or the RT or LT modifier. If it is reported bilaterally, only one unit will be considered for payment. The second indicator is the one bilateral indicator, which tells us one unit of service and the modifier 50. Modifier 50 identifies the service as being performed on both sides of the body. Do not report anatomical modifiers in addition to the modifier 50. If there is more than one bilateral procedure performed, report the services on one line. The number of units should be adjusted to reflect the number of bilateral procedures that are performed. It is recommended that anatomical modifiers only be included when the service is performed unilaterally to show the additional services are not duplicates. Bilateral procedure reduction applies and payment for both sides is based on the lower of the actual billed amount or 150% of the fee schedule amount for one unit. Ambulatory surgical centers cannot append the modifier 50. So on bilateral surgery claims, they will report two separate lines, with the first line being the RT, second line being the LT, or vice versa, but they will not report one line with the 50 modifier. So our last bilateral indicator that we will be covering is the bilateral indicator 2. So this is for the 50 or LT-RT modifiers that are not allowed because this procedure is priced to include a bilateral service. That means that your provider is already going to be paid at a bilateral service rate for this procedure. The code description includes the terms bilateral, unilateral, or bilateral, meaning it is either always performed bilaterally or it can include it on a unilateral side or bilateral sides, depending on documentation. Bilateral procedure reduction does not apply because the service are already priced as a bilateral service. Next, we have our bilateral indicator 3. Now, this is for codes that are not considered bilateral. Therefore, modifiers 50 and LT or RT are not billable. What this means is that the service reduction for bilateral services does not apply, and services are not processed based on the number of services performed. To ensure proper coding and billing of units of service, review the medically unlikely edits, or we call those MUEs. CMS reminds providers to report the bilateral surgical procedures on a single claim line with modifier 50 and one UOS or unit of service. When modifier 50 is required by manual or coding instructions, claims submitted with 2 lines or 2 units and anatomical modifiers will be denied for incorrect coding. So we need to make sure that we are billing these correctly from the start. So let's get a little bit further into what are medically unlikely edits. So the National Correct Coding Initiative, NCCI, and medically unlikely edits, MUEs, are used by the Medicare Administrative Contractors, or MACs, to reduce improper payments for Part B claims. An MUE is the maximum units of service, or UOS, that is reported for any HCPCS or CPT code on the vast majority of appropriately reported claims by the same provider or supplier for the same beneficiary on the same data service. So not all HCPCS and CPT codes have an MUE, but I will tell you, you can either go directly to the CMS website, or if your employer provides an encoder, such as Optum encoder, it provides you with the MUEs for each code. So the medically unlikely edits tables. These are downloadable tables that are available on the CMS website. And just for reference, I have included all of these links in the resources page of today's presentation. So we have DME, or durable medical equipment supplier services, for the MUE table. We have the facility outpatient hospital services MUE table. And we have the practitioner services MUE table. Now, for me, I have the most experience with the practitioner services MUE table for pro fee coding or professional fee coding. So just make sure that depending on the services in which you are billing, that you are following the correct MUE table. So let's talk about MUEs with data service and claim lines. So there are both date of service and claim line MUEs. CMS publishes which codes have a date of service and which have a claim line MUE. For date of service MUEs, the claims processing system sums all units of service, or UOS, on all claim lines with the same HCPCS or CPT code and same date of service. The MUE files on the CMS NCCI webpage display a MUE adjudication indicator of an MAI. So let's talk about the MAI. We'll talk about it further in additional slides, but this is for each HCPCS CPT code. So remember, we have an MUE and then we have an MAI, and this tells you how many units can be billed, whether it is for date of service or it is for claim line, and we're going to get further into that as we move along. So let's talk about the MAI of 1. So this is what indicates that that edit is a claim line MUE. MUEs for HCPCS codes with an MAI of 1 will continue to be adjudicated as a claim line edit. Now, if it has an MAI of 2 or 3, this indicates that the edit is a date of service MUE. So MUEs for HCPCS codes with an MAI of 2 are absolute date of service. These are per day edits based on policy. Now, if the MUE for the HCPCS codes with a MAI of 3 are also date of service edits, and these are per day edits based on clinical benchmarks. So if a claim denies based on this, it can be appealed. So Max may pay a unit of service in excess of the MUE value if there is adequate documentation of medical necessity of correctly reported units. So let's talk about that. That means that if you are searching a code and you see that there is a 2 maximum MUE, but the MAI is 3, and your provider's documentation supports 3, 4, or more units, that as long as your provider's documentation supports those additional units, if your claim gets denied, you can supply that documentation to the payer and appeal it to get paid for those additional units. Okay, so now we're going to talk about coronary artery modifiers. Now, these modifiers are very specific to cardiology. So if you are not familiar with cardiology billing, or you're new to coding and you've never seen these modifiers, these are vessel modifiers. So you will append them based on the coronary artery in which is being done. So these modifiers are typically the modifiers that are used for stent coding. So just a little background in case you're not familiar with cardiology coding. Um, if there is a blockage, or someone has coronary artery disease to a certain extent, the provider will send the patient for a cath. So they'll do the heart cath. Sometimes it's already pre-planned and they're just going in to do a stent. Other times they have to do the cath to see the extent of the disease. And if the disease is high enough, they will do a stent within that artery, and this is when you will apply these appropriate modifiers. So the LC modifier is for the left circumflex coronary artery. The LD modifier is for the left anterior descending, or LAD. The LM is for the left main. The RC is for the right coronary artery. And then to a lesser extent, some people have a ramus intermedius, some people don't. Those that do, and they have some type of intervention done, they will use the RI modifier. Okay, so let's talk about eyelid modifiers. So these are going to be more typical for your ophthalmology surgeons out there, or providers, but there are other surgeons that use these for plastic surgery or other instances that this may be necessary for, depending on the code that's billed. So these are based on upper or lower eyelid. So your E1 is going to be your upper left, your E2 is going to be your lower left, E3 is going to be your upper right, and your E4 will be your lower right. Finger modifiers. So these are specified by the hand and digit. So left or right, and then your thumb, and then it goes second, third, fourth, and fifth. Okay, so your thumb is considered the first digit, but it is classified as the thumb, not first digit. So just make sure you know the distinction so you don't get confused if having to append these modifiers, especially if you are learning to take your CPC and you're not already currently a CPC using these modifiers. So your FA is going to be your left hand thumb. F1 is your left hand second digit, which is actually your first finger. F2 is your left hand third digit, or your middle finger. F3 is your left hand fourth digit, which is your ring finger. F4 is your left hand fifth digit, which is your pinky. And then obviously it just repeats on the other hand. So F5 is your right hand thumb. F6 is your second digit first finger. F7 is your right hand third digit, which is your middle. F8 is your right hand fourth digit or ring finger, and your F9 is your right hand fifth digit or pinky. So, more commonly seen in the vast majority of specialties, whereas like the coronary, eyelids, and your hand modifiers or foot modifiers, those are more specialized to specific providers or provider specialties. Whereas side of body modifiers are widely used amongst all specialties, all types of procedures that classify a side of the body. So, when there is not a more specific anatomical modifier that can be used, such as the toe, hand, foot, etc., if it is anatomical and there is a definitive left or right, you will append the LT or RT modifier as appropriate to the side of the body. So now let's talk about toe modifiers. So these go very similar to our hand modifiers, as in that instead of being your thumb, it's going to be your great toe. So your great toe is your big toe, and then it just follows from there. So you have your TA modifier, which is your left foot great toe, which is your big toe. T1 is your left foot second digit, which is your second toe. T2 is your left foot third digit, third. T3, left foot fourth. T4, left foot fifth. T5, right foot great toe, which is your big toe again. T6, right foot second. T7, right foot third. T8, right foot fourth. And T9, right foot fifth. So now we're going to get a little bit more in depth on our X modifiers. So the majority of the remaining presentation is really going to focus on the X modifiers and proper use of modifier 59. I'm going to tell you why this was done. These are some of the most overutilized, misunderstood modifiers that are in the book. Okay, they are either billed inappropriately due to unbundling, they're billed inappropriately to not using the appropriate X modifier for what you are using it for. And we see a lot, and I mean a lot of denials with the X or 59 modifier. So I felt that it was very appropriate to spend the majority of our time really focusing on what are these modifiers, how are they used, and what appropriate documentation should look like. So let's get on into it. So we have modifiers XE, XS, XP, and XU. So we define these modifiers as XE is for a separate encounter. That is a service that is distinct because it occurred at a separate encounter. You only use the XE to describe a separate encounter on the same date of service. This modifier does not apply to a separate date of service or during the same encounter in the OR or wherever they're performing this procedure. The XS modifier, this is for a separate structure, okay? A service that is distinct because it was performed on a separate organ or structure. So remember, okay, that doesn't mean another part of the liver if you're already performing a procedure on the liver. That would be if you're performing on the liver and then you also perform on the gallbladder, kidney, etc. The XP modifier, this is for a separate practitioner. So a service that is distinct because it was performed by a different practitioner. This is typically going to happen when multiple procedures are done on the same patient within the same practice, specialty, and or subspecialty. You would not need to use this modifier if it was two different providers of two different practices, two different specialties, and subspecialties. Then we have our XU modifier. So this is unusual, non-overlapping service, and in my opinion is probably the most underutilized, misunderstood of the X modifiers. The use of this is for a service that is distinct because it does not overlap the usual components of the main service. So sometimes your providers are going to perform two procedures that are very similar, but there are certain components that do not overlap the other procedure. And as long as it's documented appropriately, then you can utilize the XU modifier. So let's get in a little bit further on the proper use of 59XE, XP, XS, and XU modifiers. So the Medicare National Correct Coding Initiative, we already talked about, NCCI, includes procedure to procedure, or PTP, edits that define when you shouldn't report certain HCPCS or CPT codes together in all or most situations. So these edits allow the following. So for NCCI procedure to procedure edits with a correct coding modifier indicator, or CCMI, of 0, don't report codes together by the same provider for the same patient on the same data service. Okay, I'll repeat that. Same provider, same patient, same data service. If you do report the codes together on the same data service, the column 1 code is eligible for payment, and then Medicare will deny the column 2 code. If you are new to coding or you're not familiar with these, I suggest that you get very familiar with column 1, column 2 code procedure to procedure edits. These are very essential to knowing whether you can bill two services together, if it is going to deny across the board, or if the modifier is allowed if the documentation supports it. So for NCCI procedure to procedure edits that have a CCMI of 1, you can report the codes together only in limited circumstances by using the NCCI PTP associated modifiers, which is what we've already covered, your 59 and your X modifiers. So the CPT manual defines the modifier 59 as a distinct procedural service. So basically what that's saying is that if the documentation supports that this procedure or service is distinct or independent from the other services, remember, this is not an evaluation and management um, modifier. This is a procedure modifier. So you never want to see the modifier 59 on a evaluation and management services. Okay, 59 is specifically procedures and services other than evaluation and management services. Okay, so in certain circumstances, it's appropriate to bill both codes. And like I mentioned earlier, if it's a different session, a different procedure or surgery, a different site or organ system, a different incision or excision, separate lesion, or a separate injury or area of injury in extensive injury. So say it's like a motor vehicle crash or something, and there are multiple injuries where it may even require multiple surgeons of different specialties to help get this patient back in place, or, prevent death in certain circumstances. So I want to highlight the incision or excision area. So most of the time in general procedures, there's one entry point, one exit point. They're doing it all through that particular area. But there are certain instances where a provider starts into one area, has an issue, whether it's crossing a lesion or, can't further a wire, catheter, sheath, whatever, and they have to do a new incision and start from a different area. They need to make sure that your providers are documenting these separate incisions or excisions very well to ensure that number one, it's billed correctly, but number two, that the insurance is going to pay for that separate incision or excision for the procedure. Okay. There are certain instances when another already established modifier is more appropriate. So instead of billing the 59 modifier, you'll want to make sure that you're using the correct other modifier. And that could also be your anatomical modifiers, such as the RTLT 50, toes, hand, or any of the other like eyelid anatomical modifiers. So just make sure you're paying attention to the appropriate modifier use. Okay, so let's talk about when we don't want to use these. So we don't use modifiers 59, XE, XS, XP, XU, and other NCCI procedure to procedure associated modifiers to bypass an NCCI edit. Okay, this is super important. We do not want to unbundle services for the simple endpoint to get paid. We are billing because it's the appropriate way to bill based on the guidelines set forth. So if two procedures are actually included in one procedure code and you append a 59 or a X modifier simply to get paid more, that is considered fraud or abuse depending on the circumstances. And we as coders or providers do not want to get in trouble for incorrectly billing, either in knowledge of or no knowledge of circumstances. Okay. So modifier XE, XS, XP, XU are valid modifiers. These modifiers give greater reporting specificity in situations where you used modifier 59 previously. So a few years ago, they added these X modifiers to give better transparency to what exactly they're separating these procedures for. Like I mentioned earlier in the presentation, this could be related to um, a different session, a different provider, non-overlapping services, whatever the case may be. If an X modifier is more appropriate and that payer recognizes those X modifiers, it's best to use them. Now, CMS allows modifiers 59, XE, XS, XP, and XU on column 1 or column 2 codes. So if you want additional information, you can go to the transmittals CR 11168 and MM 11168. So the modifier 59 and XS. So either modifier can be used for surgical procedures, non-surgical therapeutic procedures, or diagnostic procedures that fall into these categories. So different organs. In limited situations, non-continuous lesions in different anatomical regions of the same organ, but remember, they can't be of the same lesion. It would have to be a separate lesion in that organ. If they are performed at different anatomic sites, if they are not ordinarily performed or encountered on the same day, and cannot be described in a more specific modifier, such as the anatomical right and left, your eyelid, your toe, your finger modifiers, or your coronary modifiers. So modifier 59 and XE. So another common use of modifier 59 or XE is for surgical procedures, non-surgical therapeutic procedures, or diagnostic procedures performed during different patient encounters on the same day that can't be described by one more specific modifier. Okay, so this is when modifiers 24, which is separate from global on an EM procedure, 25, which is a separate and distinct from a less than 10-day global procedure, 27, 57, which is a decision for surgery, which only applies to the day before or the day of a global procedure. 58, which is appended to the surgical procedure if it is staged. 78, which means it is related to the procedure that originally put the patient in a global period. 79, which means it's unrelated to the procedure that originally placed them in a global period, or modifier 91. Now, 27 and 91 are not typical for professional fee coding. Next, we have modifier 59 and XU. When you perform a diagnostic procedure before a surgical procedure or non-surgical therapeutic procedure, and it's the basis on which you decide to perform the surgical procedure or non-surgical therapeutic procedure, you may consider that that diagnostic procedure be separate and distinct if it falls in one of these three categories. Okay, it occurs before the therapeutic procedure and isn't mingled with services the therapeutic intervention requires, which means to do that procedure, it has to be done, clearly provides information needed to decide whether or not to proceed with the therapeutic procedure. A lot of times this is doing a cath and proceeding with a intervention. Sometimes they are done at the same site, or sometimes they are done at different times. But sometimes a cath is required before you can do that procedure. Now, remember, that if they've already done the cath, they already decided to proceed, that a intervention is necessary. If they do an additional cath before the intervention, you can't get the second cath unless there is a new symptom or something has changed on the patient since the previous cath. And that's all for the instance of cardiology because that's where most of my background lies. And then the last one is that it doesn't constitute a service that would have otherwise been required during the therapeutic intervention. So let's look at this first example of a column 1, column 2 code situation. So this is for CPT code 11102 and 17000. So CPT code 11102 is a tangential biopsy of the skin. This could be shave, scoop, saw rise, or a curette, single lesion. CPT code 17000 is a destruction, which could include laser, electrosurgery, cryosurgery, chemosurgery, or a surgical curettement. It's a pre-malignant lesion, such as an actinic keratosis, and is the first lesion. Okay, you may report modifier 59 or XS with either the column 1 or column 2 code if you did the procedures at different anatomic sites on the same side of the body and a specific anatomic modifier isn't applicable. If you did the procedures on a different side of the body and used modifiers RT or LT or another pair of anatomical modifiers, you do not use modifier 59 or XS. Example 2, column 1, column 2 code situation with 47370 and 76942. CPT code 47370 is a laparoscopy surgical ablation of one or more liver tumor or tumors by radiofrequency. Your second code is your 76942, which is your ultrasonic guidance for needle placement for biopsy, aspiration, injection, or a localization device with your imaging, supervision, and interpretation. or your SNI, as some of us call it. Do not report CPT code 76942 with or without modifiers 59 XE, XS, XP, XU if the ultrasonic guidance is for needle placement for the laparoscopic liver tumor ablation procedure 47370. You will only report 76942 with one of these modifiers if the ultrasonic guidance for needle placement is unrelated to the laparoscopic liver tumor ablation procedure. Example number 3, column 1, column 2 code 93453 with our 76000. So our CPT code 93453 is a combined right and left heart cath, including intraprocedural injection for left ventriculography, imaging supervision, and interpretation when performed. And our 76000 is fluoroscopy, separate procedure. Remember that. Up to 1 hour physician or other qualified healthcare professional time. Now, just as a side note, anytime you see a separate procedure indicator in parentheses, we want to make sure we're paying attention to that in the CPT procedure detail. We don't report 76000 with or without the modifiers 59 and the X modifiers for the fluoroscopy in conjunction with a cardiac catheterization procedure. Now, you may report 76000 with modifiers 59 or X modifiers if the fluoroscopy is performed for a procedure unrelated to the cardiac cath. And back to that separate procedure. Okay, when you see that, basically what that means is there are certain procedures that it's just bundled with. If they are performed together, you can't bill separately for them, okay? And there's many instances of that throughout the CPT book. Our example number 4, column 1, column 2 code is 11055 with our 11720. So CPT code 11055 is for paring or cutting of a benign hyperkeratotic lesion, corn or callus, and this is for a single lesion. The CPT code 11720 for the debridement of nail or nails by any method, 1 to 5. Now, do not report CPT code 11720 and 11055 together for services performed on skin distal to and including the skin overlying the distal interphalangeal joint of the same toe. Okay, remember, the same joint, same toe. Don't use modifiers 59 or the X modifiers if you debride a nail on the same toe on which you are to pair the hyperkeratotic lesion of the skin on or distal to the distal interphalangeal joint. Now, you may report modifier 59 or XS with the code 11720 if you debride 1 to 5 nails and you par the hyperkeratotic lesion on a toe other than the one you debrided. Okay? Or the hyperkeratotic lesion is proximal to the skin overlying the distal interphalangeal joint of the toe on which you debrided the nail. Okay, so remember, you want to be looking for it to be proximal or distal. Remember, distal is a no, proximal is a yes. So here are the resources for today's presentation. If you would like to read further or save these resources in your daily coding. Thank you all so much for listening to today's presentation. I hope you enjoyed it. Again, my name is Kristen Robinson with the Coding Corner. I am on LinkedIn if you would like to friend me, or we have the Coding Corner Facebook group on Facebook, as well as the Coding Corner YouTube channel in which this has been uploaded to.